Thank you. Very much appreciate being here today. I was asked to speak, but also felt very educated and encouraged by our first speaker, the keynote speaker, just to give a personal experience that I was thinking about as he was presenting. Dr. Penniman talked about I do a lot of work in Asia, working with various ministries of health in a lot of developing countries, working with them on surveys and epidemiology. And as I'm traveling from one nation to the next, I do try and get some recreation time in there. And I was climbing a pyramid structure in Cambodia on my last trip, and I got a little bit intrepid, and I slipped and fell, and had a little bit of an injury that probably would have been very routine had I been here in the United States, but some of the local doctors, when they looked at it, said, well, given the amount of bacteria and viral pathogens in the environment here, you've got to take this injury to your knee a little bit more seriously. And I kind of did, and I kind of didn't, and I got from my recreational self back to this very full itinerary, and I was sitting in the Phnom Penh airport, and this injury to my knee started getting very painful and some discharge to it, and I began to feel that stress level, and I remembered my health plan at Loma University has something called International SOS. It was my first time ever using it, and I just remember some HR person screaming at me before I left, make sure to download the app, make sure to download the app. I didn't even know what it was. I was at the LAX airport, and internet was, for whatever reason, a little bit difficult, but I was like, well, maybe I should download the app, and I did, and I didn't give it too much thought. And I'm sitting in the airport, and I hit on this International SOS app, and it was absolutely amazing. They connected me to a nurse in New York City who told me to take my phone, point it at my knee. They call me a doctor. I'm a doctor of numbers, epidemiology. So, you know, if you have a heart attack, you still need to call 911 around me. Right? Got to dialogue with her, sent her a picture of my knee, was told that everything was indeed fine, and if it was still bothering me, she could connect me with a provider in Seoul, Korea, on my way to my next destination. And I began to think about our speaker and thinking to myself, well, in the end, Pramil, it was just a skinned knee. If it was a nurse practitioner or a very informed AI program, it was a message from home. And I think the biggest aspect of healing that went on with me was I was able to reach my health plan from the Phnom Penh airport, and that probably was 80% of the healing that went on so I could get to my next location. So I just felt very excited about our keynote speaker and excited to be here today. No relevant commercial interests. As Dr. Penniman said, I've been hanging around a university for 20 years and haven't particularly gone entrepreneurial in the topic today. All of my geographic information systems work is currently sponsored by the National Institute of Health, Fogarty International Center. I'm also trying to bring some of those applications home, and more recently, California Department of Public Health is also sponsoring some of the GIS work I do in San Bernardino County. I'm here today to talk about geographic information systems for healthcare, research, practice, and management. I'm sure most of you have heard about GIS at a meeting. Maybe many of you have an ARC info on your desktop. GIS is something that I took my 14-year-old daughter to the ESRI meeting. ESRI is one of the big providers of ARC info software, and spatial thinking is really being disseminated by that company and others even to our children in middle school. And it is something that is a skill of the future to bring geography into everything that you do in terms of relating it to other variables in your life, whether you're doing health or other things. And so I think one of the things in education and research that we really need to do is to begin to disseminate that information and get everybody doing spatial thinking, not so much just turning it over to a quant in your office. And so hopefully from some of what I'm going to talk about today, and I'm going to try and cram quite a bit in here and give you your money's worth, whether it's CME or other areas, is to give you some learning objectives so that at the very least at the end of this, you're beginning to think about spatial research questions in your field. And so our learning objectives from my presentation this morning are to be able to articulate at least 4 key areas where geographic information systems can enhance healthcare. And I'm saying at least because when you get into it, you could come up with 100, but I'm going to sort of group them into 4 groups, if you will, that I present today, to identify different GIS data types that can be used for healthcare management and research, to formulate research questions, which I think everybody should do. Spatial questions should not be, again, the domain of what you perceive as the quants. Everybody in the healthcare environment should be thinking about that because place matters. And hopefully by the end of this, you're going to see some very compelling examples of how it's not just the variables that you detect on a patient, but where they are and the built environment around them. And then when beginning to task this concept in work groups, at a hospital, at a healthcare plan, pretty much anything to do with healthcare, beginning to come away from a few words that I'll say today about the difference between data visualization, which is a very, very accessible skill, and again, something that we all should be doing, versus some of the more high-level aspects of spatial statistics, and even combining GIS with much of what we heard in the first presentation with the machine learning, most especially, machine learning aspect of artificial intelligence. So I'm going to try and give a range of case studies that get into that. Very briefly then, in about 45 minutes, I'll attempt a lot, but I'll go, I'll sort of go in an overview fashion. Very, very brief introduction to GIS in terms of the Geographic Information System. As much as that might seem redundant when I think about the proliferation of technology, in fact, I almost think that we need to redefine that. So it might be good to define a Geographic Information Systems. And then key areas that they can be used in, data types. And then what I'd like to kind of end with is a series of case studies in increasing complexity about how we can apply GIS to the healthcare environment. And again, I think the first 2 is something that virtually any of us can do, might need a little bit of a seminar in GIS, and then the last 2 require some more specialized skills in statistics, machine learning, and epidemiology. So with that, I'll get into it a little bit. An basic introduction to GIS, if you're not as familiar with it. GIS is an integrated system of hardware and software for capturing and managing, analyzing and displaying all forms of geographic data. Now, that definition probably would have sufficed about 5 or 10 years ago, but what we really have to think about in a more comprehensive definition of GIS is that it includes the operating personnel and input data. And when I say operating personnel, I'm not talking about your GIS person out there with a GPS device mapping this and that. I'm talking about also all of the passive measures that are going on simply by being a human being with a smartphone and walking around with apps open that make that data available. So when we say input data, we are talking about people actively and passively contributing to a geographic information system. And then within GIS, there is the field of epidemiology that you're probably familiar with, but spatial epidemiology is where we look at when we begin to think of some of the determinants of disease, we really begin to grasp how the environment itself, the geography, and where you happen to be is really a risk factor itself. And we're not just talking about exposed to a chemical. We're talking about the concepts where even some of our scientists in obesity are beginning to say it's your friends and the people you spend time with more than your genes that are more of the risk factor for obesity when we begin to look at the actual burden of disease. So spatial epidemiology. So how can we use GIS to innovate in healthcare research and management? I'm going to go over 4 large areas very briefly. One is one that you're probably already familiar with. It was the early GIS of just looking at spatial trends in health outcomes. And this is something that any of us can do. ArcInfo is a software, for example, from ESRI that is freely down. There's an online free version of it. You could download that in a few minutes, and with a little bit of reading about local indicators of spatial association, if you've got the basics of geography and cartography, you can overlay, for example, data on air pollution and mortality data and come up with a basic LISA statistic that tells you whether there's a spatial aggregation that relates air pollution and mortality, let's say, across the map of the United States. Where we're beginning to innovate, and again, the LISA statistic is something that could be done at the undergraduate level or even at the high school level, and it's wonderful to see many of the people that are generating software like ESRI trying to get some of that learning out to my daughter's class in middle school. But what we know in epidemiology is that when we're relating two variables to each other, there are many, many confounders and interacting variables and intervening variables, and it's the sciences of what those of us that have been in epidemiology have been doing for many decades. And we do bring that into the spatial arena. And so where we are continuing to innovate that, for example, in healthcare management, is beginning to say, well, it's beyond the LISA statistic. We need to be able to link some of these spatial trends with some of the basic regression models and account for confounders when we want to really be able to make strong statements like, for example, does air pollution cause mortality? Something that, for various reasons, has even come back to being controversial again. And so those of us doing that type of work have to be able to account for all of the variables, for people saying, well, you know, it could be associated with poverty and other things. And we have innovation there in terms of being able to take models like the Cox model and autoregressive models and this type of thing and incorporate them into the basic spatial software. And then one of the ones that's probably the most exciting area in geographic information systems right now, which is the idea of wearable technology. I've been in epidemiology long enough that it used to be that we would get the data collection by mailing you a 50-page questionnaire on your lifestyle. And in fact, we've been doing that at Loma University for very, very healthy, long-lived people for close to 60 years. And now what's really going on is that, as we heard in the last presentation, we walk around with computers in our pocket. We walk around with cameras and recording devices in our pocket, all in one particular device, or maybe for many of us, multiple devices. And the question is, what is the extent to which we can leverage in the GIS system this wearable technology for personalized healthcare? And I think one of the most exciting things on the horizon in my field in research and epidemiology is this large-scale cohort study, and it's really quite wonderful in terms of how it's being done, because large-scale cohort studies tend to be very expensive. To give you an idea, from my university, Loma University, we've been funded for 60 years to study populations of Seventh-day Adventists who don't smoke and don't drink, and I'll be talking about that a little bit later, but and have a very interesting diet feature, and they've been long known to have low risk of cancers, and the feds funded us for years to do it. But it's just us. We've very much owned the data. It's been very proprietary. But there's something on the horizon, because no individual university is able to win grants in the $300, $400, $500 million range, and or also cross across all the federal barriers to being able to get onto everybody's cell phone, whether you're Sprint, whether you're Verizon, whether you're some Cricket Wireless or this type of thing. And so the feds had to get into it themselves on this wearable technology, and they funded, from the Cures Act, the All of Us Cohort as of December 2017. $270 million to enroll a random sample of 1 million Americans in a cohort study that we're going to follow them forward. Now, though that cohort is also going to be using a lot of wearable technology where we will be able to monitor their daily life and then relate that to cancer outcomes. Some of where that's going, because that is just starting enrollment and they're bringing a lot of public-private partnerships in, for example, is that the wearable technology, in addition to coming up with the location of where the subjects are, they are working with Fitbit, who just had a large contract to work with the All of Us cohort and directly with NIH. They are pilot testing an initiative of a modified Fitbit that also gives your location and spatial location, doing it in 10,000 participants of the cohort. And so we are going to be able to look at both place and temporal measures in 1 million Americans in a way that's never been looked at before. The other wonderful news about it, it's not going to be owned by any one particular university. They are talking about an era with the All of Us cohort of citizen scientists, and anybody can access that because, after all, it comes from our tax dollars. Even the data sets that are sitting at universities where I work on, and we put in all kinds of proprietary stuff because we want to publish it and expand our CV, this one will be accessible to anybody. So wearable technology is going to be huge for GIS and healthcare. Then the other one that we are beginning to see is a treasure trove of information, both as health data, and I'm going to talk about that later in this presentation, and as location data, is social media itself. And it's a complex one. It's going to need a lot of machine learning. It's going to need a lot of AI to get to the bottom of it. But it is here, and I'm going to show in one of my case studies that, in fact, it may be as accurate in some cases as our traditional surveillance measures in getting us some of the health outcomes. Very brief example here from a paper that I pulled. This group actually was able to download from the 2015 to 2016 data 79 million tweets on national substance abuse patterns, alcohol and tobacco they gave some focus to. And then they ran the tweets through an AI routine that was able to classify them into happy tweets and sad tweets about alcohol. And this was the tale of Twitter and alcohol in terms of looking at it nationwide in terms of our tweets. This is just at the very surface of things. It seems like in states like the Northeast and Kentucky, where they make a lot of bourbon, in North Carolina, Illinois, Colorado, Montana, we have a lot of happy people who are drinking alcohol and tweeting. Here in California, we seem to be about moderately happy with our drinking and our tweeting at the same time. Where we seem to have people drinking, tweeting, and sending very sad tweets tends to be in Texas, Oklahoma, Kansas, North Dakota, Wyoming, and Utah, also Louisiana and Mississippi. And I'm sure there's conclusions there that's well beyond healthcare management, but it just shows the surface of what we can do with health variables and social media. I'll get much more serious with my social media stuff when I hit influenza in one of the case studies. And then finally, in evaluating healthcare services, GIS is absolutely invaluable in an era where, again, we heard in the first presentation about whether we're going to go telemedicine or whether we're going to continue to worry about how people access their providers at various facilities. The locations of those facilities is crucial. And the VA system has done quite a bit in terms of being able to where they locate their VA primary care facilities, their outpatient facilities, and they do quite a bit of work in GIS in that area. Okay, and then very briefly, this is a seminar format, and I don't want to put my professor hat on and start lecturing you on what is data and all the rest of it. So let me go through it very quickly, just so that when I mention a few things in the case studies, we're all on the same page in terms of what geographic objects and data are. The basics on GIS data and geographic objects. It's about bringing into the healthcare analysis geographic objects like polygons, lines, and points that you would see on a map. There's a concept of a raster, which has geographic coordinates and latitude and longitude on it. that you end up coming up with a row and column matrix that you add to your data set that also has individual variables on, let's say, for example, patients. There's then a GIS attribute table that finds itself into most of the GIS software that is both going to be giving you data at the level of a geographic entity and at an individual level, and sometimes melding the two together. And there's quite a bit of informatics in putting together the attribute table so that you can relate individual characteristics to spatial and geographic characteristics. And so the thing as a major take-home point is that sometimes I find myself in the GIS that I'm doing, 80% of the work is putting the attribute table together and being able to handle both spatial and non-spatial data together. And if you're putting your proposals together to be able to do GIS in your field, you really want to give that its due in terms of giving an amount of time to put together your actual geodatabase before you start to analyze it. Oftentimes with the most simple analysis, it ends up being very, very quick in terms of being able to use the package software to then get to your results. And the limiting step is your attribute table. What can we do with GIS? And this is where, when beginning to think about how you're going to staff the GIS workforce in healthcare, there's many, many different models. And some people say, well, we've got a GIS unit and we're doing things. And I want to have a sort of a learning objective to take away from here. Some of the way that the field is sort of divides into using the methods, and you can do that on a lot of the software, for straight visualization, which is very, very important. But to be able to sort of look at a distinction between that and the skill base really needed for spatial statistics, and then spatial statistics and maybe in combination with artificial intelligence. So the basics of it in terms of visualization, viewing imagery, 3D models, can be done by anybody with a few hours to spare and the patients to go through, let's say, an ArcInfo tutorial. Creating maps, a lot of that is done by data that's already within a lot of the existing software. Buffers is something that can have some analytics associated with it, where we take various locations on the map and we create buffers around them, and then we begin to put analytics on top of that and begin to run calculations on percent of people or conditions occurring inside the buffer and outside the buffer. And then there's a whole field in that of beginning to say, okay, how does our hypothesis or our outcome change as we begin to expand the buffer? And I'm going to be giving an example a little bit later on of looking at how does our viewpoint change when we look at 2 miles outside the hospital, 4 miles outside the hospital, 12 miles outside the hospital, and run the same analysis again, and what types of conclusions that is giving us. So creating buffers, visualization, but can also get into some aspect of the analytics. And then we get into the actual fundamentals of spatial analysis, which also crosses into the field of epidemiology, where we're actually getting in there with the statistics and we are testing research-level hypotheses that we've done for years with non-spatial data. And there's a whole suite of statistics and dashboard of tools that we continue to innovate. I'd like to give a shout out to my colleague, Dr. Sudipto Banerjee, who wrote this article in Annual Reviews of Public Health. It's called Spatial Data Analysis. He's the co-investigator on my NIH grant and the chair of biostatistics at UCLA. And he's written an absolutely amazing article on how to bring together much of what we know about regression and cure models and Cox proportional hazard models and bring it into the spatial arena so we can test all of the hypotheses we always have for risk factors for disease, but at the same time also test the concept that place matters and the built environment around the patient or the subject or the primary prevention target also is important. And so, for example, very basic example from his paper in Annual Reviews of Public Health is looking at in a particular state of the union here, lung cancer. Does it actually spatially aggregate in this state? And you can look at it visually, and oftentimes you can do that on your job site. with the region outside the hospital and just come up with conclusions there. But if you're trying to do what we tend to do in academia and reports that we try and disseminate in the journals, we need statistical significance and coming up with the concept of a spatial correlation behind the whole thing. And autoregressive modeling right now is probably the most innovative thing that's out there in terms of being able to deal with all of the aspects of spatial correlation and still put the risk factors in the model. Briefly on GIS software and data, you really don't have to go far to get a lot of the spatial data sets anymore. Our county, state, and federal agencies have a plethora of geographic data that's out there that can be used in health, both at the county health department level. Here in California, the OSHPD data is all geocoded. And then our own U.S. Geological Survey has just a huge, huge amount of data that you can get. In academia, most of the libraries have now a set of geodatabases, whether you're trying to look for things for your state, your city. The MIT libraries have made most of their stuff open source, so you don't have to be an MIT student or faculty to get into it. Claremont happens to be on here because I just gave a presentation a few months ago at Claremont about the GIS, but it's there at most universities. One of the pioneers of software that's right here, as was mentioned in Redlands, California, ESRI, that creates the ArcInfo software that's most commonly used in a lot of the GIS applications. They also, packaged in their software, have a huge amount of data that you can already use. And contacting the company, you'll find, and I work very closely with ESRI on some of my work in Asia. They are continually trying to build their knowledge base of geographic databases from various nations. So they are not just here in the United States. It's very much of a global concern. The United Nations goes to ESRI to get a lot of their geographic data for some of the work that they are trying to do in the area of planning. Okay, so I think I'm doing okay on time, and so I'd like to try and get into some of the case studies that I brought today to try and give some learning objectives to this presentation. And I'm going to present them in order of complexity of the GIS. So let me kind of give a general overview. I'm going to do one of the national obesity trends, and then looking at it in all adults, and then a very specialized group of adults. The competency for this type of analysis is actually quite simple. It's using basic visualization tools on ArcInfo, something very accessible to all of us. Sometimes when you see the word statistics, people in healthcare want to say, well, we're going to have to leave that to our numbers people. Really, let me encourage you that spatial thinking and kind of getting into it with some of that software can really be the domain of all of us. And I see an obesity case study like this is something that uses the basic pull down. You don't have to be a coder. It uses the basic pull down visualization tools within ArcInfo. And all you're really doing is clicking on a box to say, give me the spatial aggregation here, and it will give you your results. And so one that I think that's accessible to all of us. Little bit step forward is the nurse management case study. That one of the things I like about this study is that it wasn't published in the scientific literature. It's not an academia domain. Despite the fact it was done at Stanford, it was really something that the Stanford Human Resources people did. We're talking about the hospital human resources people did to look at the concept of nursing shortage. And again, it's using simple components of the ArcInfo software on buffer zones, and even at a visual level was able to identify something very, very powerful for the Stanford group on how to manage nurses at their hospitals. Then I'd like to move up in a level of complexity to something related to looking at healthcare accessibility with one particular city. This was done in Seoul, but it really tackles all, if you're just trying to say, we've got public hospitals, private hospitals, how do we spatially study the accessibility of the population, let's say of the city of Seoul, to those hospitals? When you think of the myriad other variables and how they interrelate, It is non-trivial to answer research questions there. And this is one that had to go beyond the basic stat package and had a lot of spatial statistics and mathematics in it to get there. And the reason for presenting something like this would be to prevail upon you that when you look at something like healthcare accessibility that is so multivariable, that you really would want to staff that with spatial statisticians and even beyond to get to where you want to go. And then when we bring social media in, most especially because it's a messy data set and it's text mining, the real power in the final case study of combining GIS with machine learning to be able to extract all that we can from this new treasure trove of information from our social media. Okay, so moving forward into a first case study, national obesity distribution in all adults, and then I'll talk about a very specialized set of adults that we've been studying at Loma Linda University for about 60 years. Here is our percentage of age-adjusted obesity in the United States. You can see that it is non-random geographic distribution where a large proportion of our obesity is going on in the southern states. This feature has been known to the National Institute of Health for a number of years, and they gave a huge grant, I think it was about $25–30 million, to a professor, George Howard, at University of Alabama, to fund what's known as the REGARD study, Reasons and Geographic and Racial Differences in Stroke, for the mnemonic REGARDS. And what they really want to get into was answering the questions, why is it that we have such an epidemic of obesity down south, and be able to look at risk factors, both spatial and non-spatial, in what's become known as the nation's stroke belt. Okay? And so it focuses on this region of the country where there seems to be a convergence of obesity, convergence of stroke, and they've gotten into all kinds of aspects of diet and even aspects of the communities, not enough walking trails. I have to confess, and I don't really feel I have the biases associated with it, but I have been a coastal person for most of my life in the United States. Dr. Pennyman said I was born in New Zealand, but I came here at 7 years old, so the New Zealand accent's gone. I do have to say I've spent most of my years in either California or on the East Coast. But my daughter right now is living in Missouri, and so I've been spending some weeks in Missouri from time to time, and then I began to see what you can say is some of the huge cultural differences between the types of businesses I see in California, and then when I was driving around Missouri, and it seemed like every sixth block I saw a restaurant called Steak and Shake. And I was like, there is some of the risk factors behind the stroke belt going on over here, coming from the land of probiotic yogurt stores and stuff in Southern California. I was like, Steak and Shake. So just in case you didn't get enough saturated fat with the steak, put a milkshake on top of the whole thing, normalizing a wonderful diet for that region of the country. So they gave quite a bit of money towards this, and they did some wonderful GIS analysis and other risk factors and all kinds of interesting, again, cultural things. And they found in some of the rural communities there was these bottles of oil on top of the ovens, and some of them was the chicken grease, and some of them were the bacon grease, and all of this, and relating all of this to our stroke belt. And that had its GIS and its statistics behind it. Now, we got into something at Loma Linda University. In our studies, we are a Seventh-day Adventist university and medical center affiliated with the Seventh-day Adventist Church. And in Loma Linda, California, where our university is, we were selected in... How many of you in here have heard about the concept of the blue zone? This is Dan Buettner from National Geographic. He did a sort of qualitative study where he went literally globally to look at all of the regions on Earth where we have this significant proportion of people who are living well over the age of 100 years. And he was trying to answer the question, well, if I just go and talk to these communities, what common factors can I find that would promote longevity? And so you can see you've got Okinawa in Japan, Ikaria in Sardinia in the European region, Nicoya down in Central America. And in fact, the only US blue zone where we have people living a long time is Loma Linda, California. And the reason why, probably, and this is where it gets nuanced in terms of the answer, because you might say, okay, if you look at Loma Linda, it's a city that is predominantly inhabited by Seventh-day Adventists. We have our university there. We have our flagship medical center there. And you might say, okay, well, it's a bunch of Seventh-day Adventists who don't drink, don't smoke, and are promoting vegetarian diet, and they're about halfway successful. About half of our Seventh-day Adventists that are enrolled in our NIH study actually are practicing this plant-based diet. So done and done. That's why these Seventh-day Adventists are so healthy and they live a long time. Well, it's just the ones in Loma Linda is the blue zone. Here's the interesting GIS analysis that we then did. So we recognize the fact that in Loma Linda, you have all of these individuals. They keep a healthy weight. They're eating lots of walnuts, regular exercise. They've got tight social networks, so on and so forth. But in fact, U.S. Seventh-day Adventists, it's a Christian denomination that was founded here in the United States. What the NIH has funded us to do is a study of 96,000 Seventh-day Adventists living all over the United States and in a few provinces of Canada. This is a multi-million-dollar initiative. To date, they've given us about $14 million from National Cancer Institute to study the Adventists living in every single state who are living around, obviously, non-Adventists, and seeing what they are doing and how some of their risk factors might impact disease. So we looked at it in a GIS analysis, and interestingly enough, if you're looking at these LISA statistics, and if you look at the red one that says high, high, that's where we're saying that for obesity, a high, high designation would mean spatial aggregation. And the very interesting conclusion that we've come up with from our GIS analysis is, in fact, if you notice where most of the high, high regions are, where you've got obesity clusters in Seventh-day Adventists, they're all occurring in the stroke belt. So in other words, what are we really saying there? As much as the Adventists are exposed to this councils of diet and health at their church, and they're living all this wonderful life, yes, the ones in Loma Linda who are living around each other, and if you will, control the town, they're doing quite well, and they're a blue zone. However, where everybody else is living in the stroke belt, the Seventh-day Adventists are also gaining weight and turning obese. In other words, place matters. They're getting influenced, if you will, by the steak and shake shops in their community too. So it's not just about having even religious motivations for doing things. If your environment doesn't predispose you to living a healthy environment, you may be suffering the consequences. So we found this, and this is an example of GIS in play, p-values of less than 0.001, showing that we found significant obesity clusters among the Adventists right where all the rest of the Americans are obese in the stroke belt, saying that we need to look at environmental factors and the location of people in what we are doing. Final conclusion being, in more obesogenic counties, Adventists are more likely to be obese than in counties with the lower obesity prevalence. This has given rise, these type of data that we have on the blue zone and what's gone on then with Adventists nationwide, for things that we are doing at Loma Linda itself to begin to say, what is it about Loma Linda that has made it a blue zone? And we actually convened a conference called Healthy Communities by Design and began to study our own city and begin to see that because we have walking trails, because we have that many more swimming pools, because we have that many more stores that are selling fresh vegetables, there's a lot in the environment of Loma Linda that's influencing people, so it's not some fountain of youth where there's something magic in our water type thing that's going on to make us a blue zone. It was the design of the community itself, along with all of the faith-based influences, that was really making that a blue zone. And Dan Buettner, who's trademarked the blue zone, is off now taking some of those principles And he's gone very entrepreneurial with it, and he's going city to city to try and help them turn their city into a blue zone. So moving onward, case study number 2, the healthy model for a nursing workforce management and planning. And so what I'm presenting here is an example of buffer zones in GIS. And this is something not published so much in the scientific literature, but that Stanford University Medical Center did to study its hospitals and its hospital system. And so I hope the slide is clear enough that you're able to see these circles that each have an H at the center of them. I don't know if I have a pointer up here. Oh, here we go. Yeah, circles that have a center to them. These each represent a component of the Stanford University hospital system. Now, what Stanford was very concerned about, and if you know this area up near Stanford and San Francisco, Palo Alto, very, very expensive real estate up there because of all of the tech industry people and all the rest of it. You can wind up in a little apartment costing you close to $1 million, these types of things. So when you've got such a large hospital system, how do you get somebody who's not a tech millionaire, let's say, for example, a registered nurse, to live close to the hospital so that they can be there, most especially for emergency purposes, so on and so forth? And if you see the darker regions, meaning where we've got the most nurses living there, let me go there. So this is a GIS map using the registered nurses' addresses because they all have licenses, so we're able to find out, where they live. 2,700 registered nurses living in the region of those hospitals where they're working. Well, what we can see is that you've got some of them who are living very close to the hospital where they work. And then others you've got regions down here where certainly you've got the hospitals, but you don't really have a huge number of nurses living near them. In fact, many of them are living across the water source over here, across this bridge, and they're living across the bridge in other regions. Now, this was in fact a concern for Stanford Human Resources, because what they were saying is we need long-range workforce planning to make sure that we have an adequate number of nursing staff, both living near the hospital and in the case of an emergency. And so HR mapped and analyzed these hospitals and the nurses living near them to be able to say, okay, what is our nursing supply? What are their commute patterns? And how do we begin to answer questions like this? If the nursing population living within a 6-mile radius of our hospital is projected to retire in 10 years, but the average home price in the area has become far too expensive for just about any clinical professional, how will we be able to attract new entrants to our workforce in this location? What nurse who's working a graveyard shift wants to be living 25 miles away, right? So that becomes a very interesting situation. Also, what if we experience an earthquake in the middle of the night and the majority of the nurses are living on the other side of a major bridge and can't get there? Okay? And so what they began to do was use this concept of buffer zones and progressively looking at buffer zones 2, 4, and 6 miles beyond the hospital to begin to answer questions about who are the nurses, how long have they worked at that hospital, what is their retention rate, and how can we actually keep them within the workforce. And what they found that was a very, very interesting finding was that the nurse comfort zone for Stanford University Medical Center was about a 12-mile radius. That's where you got optimal results in terms of nurses making it in to the hospital and then also being able to retain them on the workforce. And when looking at non-spatial variables, what they were able to find was that to be able to retain nurses at that hospital at a time of nursing shortage, if they were living within 12 miles of the hospital and you were able to get them to a milestone of at least 3 to 5 years of service, these were the ones that were going to stay on board until they retire. Now, at Loma Linda, we have actually been using a very similar procedure here to be able to staff, because the region around our medical center, and we were just building a $1.2 billion children's hospital, we're trying to attract providers, nurses, allied health professionals into the community, and some of the houses are getting kind of expensive. So even an analysis like this has affected us, because we are beginning to do things like down payment credits in certain planned communities right next to the hospital, where if you're a Loma Linda physician or nurse, you only have to put 5% down on the house with the builder. So it's a sort of collaboration between the builder for affordable housing and the medical center to make sure that we have enough providers to staff this medical center. So overall, from a GIS analysis like this, we're able to see that GIS for Stanford helped free up $22.5 million in replacement and retraining costs over 2 years, and it also helped anticipate and mitigate the potential interruptions to the continuity of care. Okay, so now moving up in the level of complexity here is a case study which is looking at literally healthcare accessibility in the city of Seoul. Seoul has 10 million residents to it. Their healthcare system is a little bit different to ours in terms of accessibility and their whole model of healthcare. But I think this example really shows the complexity and how sometimes, and this is probably one of the biggest pitfalls with GIS, is that a lot of us now, we have the ability to do this point and click pull down menu on an ArcInfo, and you think you've done a GIS analysis, let's say, of a city that's going to tell you healthcare accessibility, and there are a lot of fallacies and misnomers that such an analysis can produce if you're not taking into account all of the very complicated variables. And you have to deeply get into the math behind the programming. And so what's prepackaged in an ArcInfo may be creating a level of, if you will, spurious results. And this particular group of authors really spoke to that by going beyond ArcInfo. They were a set of spatial statisticians and doing their own thing with their own GIS software, which they programmed in R, a free stat package, to be able to get their results. So I'm going to talk about 3 different models of assessing healthcare accessibility for this region of in Seoul, Korea, and talk about some of the limitations and what was the final conclusion. So the first method of assessing healthcare accessibility with GIS software actually is built into a lot of the packaged softwares, and it's called a 2-step floating catchment area. And what they very simply do is they go to various regions. So you might take an individual subject, and that individual subject, let me point to that over there, is living, let's say, within, you might want to look at all of the hospitals you see for that subject. Let's say all the hospitals within a 5 or 10 mile radius of the subject. So then what they did is they did a supply to demand ratio. They calculated that for each of the hospitals that were around that one particular subject. So that was their step 1, and then for their step 2 to assess accessibility, they summed that supply to demand ratio across all of that, and that gave you your measure of healthcare accessibility. One of the major limitations of the approach was that it assumes equal accessibility. It doesn't, while it's saying all of the hospitals within a 5-mile radius, it doesn't take into account the exact distance. And if you went 10-mile radius and you've got people who don't have cars, that might be a major impediment there. So despite the fact it's a commonly used method, one of the major limitations is that it assumes equal accessibility of the patient to each one of those hospitals. Next is known as the enhanced 2-step floating catchment area. Here you also calculate your supply to demand ratio, but then you are actually adjusting for the travel time to the facility, and using a penalized weighting function on whether the subject is using a car or whether they're using public transport. Okay? So it was an advancement, the E2SFCA method. It was an advancement on the typical software package. That's in the literature, but it hasn't really been incorporated, let's say, into a lot of the routines on ArcInfo. Now, one major bias, and again the nuance when we start to think about place matters. One major bias even in this method, and this is one that even though I'm not in Seoul, Korea, I can fully identify this from the Inland Empire and living in Loma Linda where I am near some of these Kaiser Permanente mega complexes of healthcare facilities. It doesn't account for the large healthcare facility bias. In other words, and to draw on something not in Seoul, but here in Southern California, where I live in the Inland Empire in Fontana, which is one of the smaller towns there, which up until a number of years ago was mainly a set of truck stops and a race car track and a few houses, you have this behemoth of a Kaiser Permanente building, healthcare facility, high density of doctors, occupies about 4 city blocks, okay? Employs a lot of people, but can you actually make the conclusion that somebody living across the street from that Kaiser Permanente has huge accessibility to healthcare? Well, what we know about Kaiser Permanente, you typically have to be an employed adult. Your employer has to have bought into Kaiser Permanente. It's completely possible to be somebody living across the road from Kaiser Permanente and have very limited accessibility to healthcare. Unfortunately, in this model, this concept of the large healthcare facility bias was not incorporated. And in fact, the authors did a very convincing linear regression analysis looking at what variables actually predicted healthcare access. And if you look at the p-values, if you will, to go a little bit stat on you, where a p-value less than 0.05 means statistical significance, an important variable, average car ownership was a very strong predictor of healthcare access. High waiting time for public transportation was inversely associated with healthcare access. Total number of healthcare employees at the facility was not associated because of this bias, where you can have these large mega complexes of healthcare facilities, maybe they're surgical centers, but living next to that surgical center doesn't actually mean that you're accessing anything. So the final method used was the authors that they sort of customized this for the city of Seoul. They call it the Seoul Enhanced Two-Step Floating Catchment Area that actually used a weighting function that removed the concept of number of providers and didn't put that into the accessibility formula. And in fact, what they were able to show, and this is the city of Seoul and some of their GIS analysis, which is really quite fascinating here, is that if you notice the axis here, the reddest regions show the least accessibility, okay? So all of this red region, these red regions at the outskirts of Seoul show very, very low accessibility to healthcare, the lowest in the city. But most interesting is, here is your number of physicians with this very, very dark green being where you've got high concentration of physicians. You've got the paradox of certain regions of Seoul where you've got some of the highest concentrations of physicians occurring in areas of some of the lowest healthcare access. And so they were able to use this and even got into the sophistication of, notice that we are seeing high concentration of private physicians, so it may be individuals who are not able to access private health care. Let's take a look at the next one, public health care within Seoul. Here's where, again, the lowest accessibility even to public health care was occurring in these problem regions, all at the outskirts of Seoul, and yet the public health care that probably should be trying to serve the marginalized individuals, it's nowhere near these individuals. It seems to be, there's like, well, we're going to try and help the marginalized, but we're going to build all of our public health care facilities far away from them at the center of the city. Another beautiful validation of the linear, so you notice the spatial analysis here, validating the linear regression model that looked at transportation variables, number of cars, and your wait time for public transportation really being the major predictor variables over here, really saying, let's move some of our public facilities closer to where we've got the marginalized individuals. I am using this type of vulnerability analysis in San Bernardino County for the California Department of Public Health right now. Unfortunately, because it's for tobacco control and something very sensitive, they won't let me. I wanted to show some of the data that we're doing right now. The brief on it is that in San Bernardino County, we have a very dense municipality around San Bernardino City, but then we have all these high desert regions with very sparsely populated areas. That's our meth counties where we have some of the worst healthcare indicators. And we were trying to look at, for tobacco cessation, that's my area, where we should put some of our tobacco control programs. And this exact type of vulnerability analysis using this methodology is what we used and turned over to California Department of Public Health. What they were able to do with it, interestingly, because Proposition 56, as you may know, passed, and so the price of our cigarette pack has gone up, they were able to take that tax dollars and use it to build tobacco control facilities all in some of the outlying regions of San Bernardino County. So very powerful GIS application. So in the end, the final vulnerable region of Seoul, using both public and private healthcare, was isolated to 6 different regions that they've highlighted over here, and had a major impact on them beginning to put some of their public healthcare facilities and relocate them towards the outskirts of the city. Final case study, in terms of also complexity, is using GIS and machine learning to study Twitter data on influenza. And I find this, as an epidemiologist who spent a lot of my life in surveillance, as being very, very exciting, because we have spent most of our time in epidemiology for the last 2 decades trying to think about how do we get valid diagnoses with codes of this disease and that disease, and then we validate it against the clinician diagnosing things. And then you come along with this mess of data on Twitter, and we might be able to use some of it for surveillance in and of itself, removing some of the need for all this infrastructure. Let's take a look, but with the promise of all of that, there's a lot going on in terms of machine learning, so I don't want to get too hopeful about it just yet. Twitter messages were collected, filtered, and analyzed for the 30 most populated cities in the United States during the 2013 to 2014 flu season. Okay, so now you've got everybody's Twitter messages for the 2013 to 2014 season. What do you do with all that text data? It's almost genomic in the amount of it. Well, behind the scenes, before you can get all excited about the AI and the machine learning, is a very, very sophisticated support vector machine that was actually able to do text reading of the tweets, and it had to go through a lot of validation before they deployed it. But let's take a look at some of the examples of the tweets. And they were trying to look for tweets that would be an indicator that you actually have the flu. So if somebody tweeted, flu medicine kicked in, time for bed, the support vector was able to say, okay, we're going to classify that as a flu positive. Okay? I got to get over this flu, again, something where it was able to be classified as valid. Now somebody's randomly going into a class and one of their classmates says, I'm not going to be at the exam, or I'm not going to be at the class, and it says, who gets the stomach flu the day before class starts? Doesn't necessarily mean that that person tweeting it has the flu. Actually, the algorithm was able to diagnose that in fact it wasn't a valid thing, that in terms of being able to indicate maybe it's an influenza-like illness. I'm getting the flu shot today. Just use of the word shot and flu together was being used to make it an invalid tweet, because you're trying to prevent something, but you probably don't have it. Arm is killing from flu jab, so jab shot type thing going invalid. This flu feels like death, that's a valid tweet. So that's the big piece of work behind a lot of this. But if you can get beyond that, and if we have tight enough machine learning and AI type algorithms, here's the promise from that study. The red line here is the national rate of influenza-like illnesses. okay? And then the purple line is the peak diagnosed by just looking at tweets. The correlation between the two, extremely high, R equals 0.8545, very, very highly correlated. In other words, data in our social media can be used potentially to track some of our disease rates. There is stuff for healthcare and healthcare management that could be sitting in these types of freely available Twitter API type databases. Before we get too excited about the national level, there was some variation when they began to look at that data on the city level, where some cities had a higher correlation than others. If you were in Fort Worth, your tweets about having the flu were reasonably diagnostic about actually having the flu. Same in Cleveland. Didn't seem to be working in Boston. Maybe too many flu researchers going to the labs at Harvard talking about flu or something like that, but we just don't know. The correlation goes down to 0.105 over there. So altogether, in terms of looking at correlations, it looked like the correlation between influenza diagnosed by actual physicians and influenza suggested by looking at somebody's tweets with a machine learning algorithm, regions of the country where the correlation was especially high, Pacific Northwest and Michigan type area. Some regions in the middle of the country, region 7, doesn't seem to be as effective. So we probably continue to have to try to improve some of our machine learning algorithm, but I think the big take-home point is that social media does have health data in it if we can mine it with a level of sophistication. Okay. Finally, I have no more case studies left. I'm just going to give a few shout-outs to things that we are doing on GIS at Loma Linda University. My area is in tobacco control, and very recently in 2017, the Fogarty NIH Institute has given $10.7 million to build tobacco control and prevention research capacity in developing countries. They gave grants to American Cancer Society, Emory, Florida International University, Georgia State, us at Loma Linda, UMass, and University of Minnesota. Our grant at Loma Linda is called Building GIS Capacity into the Tobacco Control Research Programs of East Asia. I am partnered in that work with UCLA Fielding School of Public Health, Dr. Sudipto Banerjee, the chair of biostatistics there. We also have a public-private partnership with the ESRI company that creates the ArcInfo software and is working with us on some of their initial apps now to be able to mine the social media data, which is something I'm especially interested in doing, and then have the privilege to actually work with one of my students who graduated a number of years ago, and he went to work for FEMA, and he used GIS to be able to monitor tweets during Hurricane Sandy. He got very famous and was all over the news over it and got very entrepreneurial and is one of 20 founders of the Fulcrum Mobile Location Company. They have been mapping things all over Asia, and he's also helping us design mobile apps. What we are very briefly doing, one of the nations we're focusing on is Mongolia. Mongolia is a landlocked nation that is frozen most of the year at about -20 degrees. They can't grow their own tobacco. Most of their tobacco comes in illegally in smuggled cigarette packs from Russia and China. And so one of the things that we are doing is mapping the location of all of these types of cigarette packs. You might be able to see that this pack that's occurring here in Mongolia actually has a Chinese health warning label on it. This very slim cigarette pack comes from across the border in Russia. And this pack over here doesn't even really work in Mongolia because the health warning label is written in English. And what we are doing is we are mapping the location of the sales of those packs, and then I'm trying to get into a machine learning algorithm because Facebook is being used to flood the Mongolians with all types of ads and informal mechanisms of how they can go across the border into Russia and China and go to the border regions of their country and acquire cigarette packs. And so we are trying to search social media using a machine learning algorithm to be able to find out how they are getting these illegal packs. By the WHO Framework Convention on Tobacco Control, and the WHO is one of our partners in this, all of these packs should be banned, and it's part of a ratified treaty that Mongolia has already signed. And then one of the other ones that we're working on at Loma Linda University at the Medical Center is we are coming up with these patient wellness apps where when we, for example, discharge an MI patient, we actually want them to install a special Loma Linda University app on their phone, and they grant us the sort of privacy rights, if you will, to be able to beam information out to them and collect information so that we can advise them on where to shop, we can advise them on where their nearest pharmacy is, their nearest primary healthcare provider, cardiologist, so on and so forth. And what we would like to begin to be able to do is actually look at the movement of the post-surgical patient in the community, both before and after the surgery. So there's quite a bit of this type of place matters and GIS that we can incorporate in the healthcare management. So I have nothing further in terms of case studies or information for you here today. I'll open it up to any questions.